Why is AIIMS special?
The world-class professors that they have, they are the best of their field.
Like cardiology is a high pressure job. How did you psychologically handle that pressure?
Again, it depends on your mindset. You may be scared of that condition, or you may take that as an opportunity.
What kind of a person to actually excel in this field?
You need to pay attention to very minute details. You have to observe for subtle change in heart rate.
Do you think this branch breaks you over time? What are the negatives about this field?
So this branch does involve that extra effort. It may be midnight, it may be day, it may be morning, anytime. I don't think it will affect me negatively.
How should that toxicity be countered?
In an Indian setup, he wouldn't even get time to discuss the problem with his colleague. Why? Because they both are overworked.
What is this concept of bullying, ragging, assaulting verbally?
Well, certainly this should be discouraged. Such a system, if it exists in a particular hospital, the senior faculty should actually stop that practice.
Professors are driving this culture.
A senior doctor work like that with his juniors.
Students go for multiple attempts, or should they settle for what they're getting?
Depends on the person, because you can't convince a person who is mad after something, you can't convince him to settle for something less.
What is the salary structure of a DM cardiologist? We are building India's largest community of medicos, and thanks to each one of you for making it a possibility. Before I start with the podcast, I want to convey a simple message. If you are facing any problems with your authorities, government, college, university, you simply have to make a post on Instagram and tag me. I will tag all the relevant authorities. I'll make sure that all the authorities see what is happening on the ground. Our doctors need justice. Let's start with our today's guest. So cardiology, my friends, was one of the most requested branch in all our comment section. And today we have a very special guest for you. He has a brilliant profile, guys. Let me start with his MBBS, GMC Srinagar, MD in Pediatrics at AIIMS Delhi with a rank of 16, also cracked PGI with a rank 11, and then the best part, cracked all India SS exam in all the categories, whether it's NEET, whether it's INI-CT, he cracked it with rank 1, took cardiology at AIIMS Delhi, and has an amazing profile throughout India for being one of the finest interventional cardiologists of the country. Let's put our hands together and let's welcome Dr. Mohsin Raj. So welcome Dr. Mohsin to the Nachiket Bhatia Show.
Thank you. Thanks for the invitation.
Boss, you have an amazing profile. You have done everything what a doctor can think of. So I would like to know everything about you. How did you go from Srinagar to AIIMS Delhi?
Yeah, but even I wouldn't have imagined that I would do an MD and then a DM in a branch like cardiology from AIIMS. So it started with the dream of my parents. They wanted to see their son as a doctor, and seeing them happy was an enough task for me. Okay, let me do this. So that was the only purpose of doing MBBS. I had initially no plans of like any long-term plans. I want to become a neurosurgeon, I want to become a cardiologist. This was not in my book. So I just wanted to do MBBS because that was my parents' dream and I wanted to fulfill that. And retrospectively, I see it a very wise decision. And if I'm supposed to redo everything, I'll still take the same decision. I'll do MBBS only. And then I joined GMC Srinagar, an amazing college, big college, has 6 or 7 hospitals that it caters, and I had a good exposure, but something was lacking. And that, that name AIIMS, the place, I got to know only in my second year MBBS. I came to AIIMS on a social festival called Pulse. Yeah. And I saw the institute, when I went to wards, observing people taking rounds and all, it somehow, I promised to my friends that I'll do my MD here or I won't do my MD. So that was the mindset I had. And that's it. And once you have a goal, you somehow carve your way, you just reach to that goal, right, left, you just change your direction. But if you have a goal post, this is where I want to go, that's what happened. But it took a lot of effort, definitely. So that's it.
So whenever I have an Amazonian on the guest seat, they always give a lot of credit to their college as well, AIIMS. So if I ask you in one word, how would you describe why is AIIMS special?
Well, AIIMS is special because of a few things. Number one, the state-of-the-art diagnostics and treatment facilities. No doubt, you won't see such diagnostics or treatment facilities in any government institute. Number second, the world-class professors that they have, the faculty, they are world-renowned researchers. They are the best of their field. Name a subject, name a disease, you will have an expert of that disease in that place. And third, you get to mix with, people who are A++. They are like, the best medical students. They will, read a lot. They will work a lot. You get that. Sometimes competition is good. Competition is good because, you improve. Whenever I see a more competent fellow, I feel happy because that's the thing that drives me. No, I need to improve. So that's the unique feature of AIIMS. You see wonderful people, wonderful doctors, so that you get inspired. Okay, I need to improve my game. I need to do better in the next case. I need to do better in the next phase of my life.
Boss, normally what happens is students from peripheral government colleges or private colleges, they never even think about AIIMS. For them, it's a forbidden fruit कि यार बहुत competition है, it's very tough. How did you overcome that challenge?
Well, it happened to me also. Like, जो मेरे seniors थे, some of them even said that form मत भरो. It's like, useless. It will be a waste of probably उस time 1,000 rupees का form होता था, something like that. Because, people believe that it requires some special coaching. Or you just have to be an MBBS from AIIMS to get MD from AIIMS. All those myths. But deep inside, I knew that it's a matter of an MCQ exam. A question, 4 options. If you know the right option, you're through. So that's the reality. It's an MCQ exam. If you've read, if you have prepared well enough, you answer most of the questions right, you're through. You're into AIIMS. And second, if you look at the result of INICD, for example, see how many of them have done MBBS from AIIMS New Delhi? Very few. Or even if you include other top colleges like MAMC and all. So there are few people from top institutes who actually do MD and DM from AIIMS. Many people are there who have done MBBS from other peripheral colleges. I even know people who have done MBBS from private colleges. And then they did MD and DM from institutes like AIIMS and PGI. So your MBBS college rarely matters, especially with the advent of online coaching. Everybody gets taught by similar teachers, same teaching material. So those things have leveled. You can actually target any college if you want to do MD and DM from AIIMS. Just prepare. Yeah, one thing is important. You need to be a student who has a preparation of that 0.1%, those top 0.1% students. Your level of preparation should be like top 0.1% performers. So if you can do that, you can crack it.
What was the reason you chose pediatrics as your postgrad?
That was quite a funny reason, actually. Radiology was my first choice as a branch, but AIIMS and PGI, in both the places, I missed it by 1 rank. So the person just ahead of me took the seat. So then I was left with my second choice. My second choice was interestingly pediatrics and not medicine. And I was confused between the two. I chose medicine at PGI, pediatrics at AIIMS, taking time. I had 15 days to join. I thought, let me decide. I'll join at one of the places, either MD medicine at PGI or MD pediatrics at AIIMS. But I, at that point of time, thought 3 years of training in pediatrics is a sort of complete training. You don't need further super specialization. And, all these subspecialties in the department of AIIMS pediatrics, they are like under the department of pediatrics. So you get exposed to all the subspecialty trainings as a junior resident, a more complete and an overall training. That was the reason of me choosing pediatrics. But eventually I switched to adult cardiology. The reason being, maybe we'll discuss it in the next questions as you will most likely come to that. That would probably be your next question. Why did I switch from pediatrics? So I chose pediatrics over medicine because at that point of time, with that amount of mindset, mental ability and training, I felt pediatrics is better than medicine. But during my pediatrics training, as I felt that you need to do super specialization, even in pediatrics, everybody is going for DM. So then I felt, and that's how I think, that you should do DM in a branch that's more than theory. I wouldn't do DM in neurology or nephrology or endocrinology, which is just reading a few more books. I feel more theoretical. I need to do DM in a branch which has more of skills, like interventions and all. Surgery was not an option, obviously, after doing MD. So I chose cardiology. Then cardiology, should I do DM in pediatric cardiology or should I do DM in adult cardiology? So obviously, adult cardiology offers you a more broader training in cardiology. You see all flavors of cardiology patients. And then if you wish, you can do pediatric cardiology as well. After a brief fellowship of another 1 year after DM, you can work as pediatric cardiologist as well. So that's the reason I chose cardiology and specifically adult cardiology. So at this point of time, I feel everything just got connected. I now work in a branch which is more fascinating than any medical branch. I mean, the clinical examination skills of a cardiologist, listening to patient's history, doing physical exam, that's amazing. And you come up with the diagnosis. Then you work almost like a surgeon and a radiologist and a radiologist. So we do all sorts of imaging, echocardiography, CT, MR. So even that was my liking to start with. And then interventions, even semi-surgical intervention. We place devices, which involves a surgical placement of devices like pacemakers or ICDs and other things. So it's a mix of everything, which is why if I was asked to redo again, as I said, if I was asked to redo, I'll again pick MBBS. And if I was asked to again choose the branch, I'll again choose cardiology. Somehow, thank Almighty, I didn't get radiology at that point of time. Just one rank saved me. It was good for me that I was one rank behind, because now things got connected.
God always has a plan, right?
Definitely. His plans are always better than your plans and more future proof.
Considering the fact how radiology is right now burdened with AI, I think cardiology is a much more sustainable branch than radiology at this current scenario. So you have given us all the positives about cardiology. You have lived the life for last 4 to 5 years. What are the negatives about this field?
Negatives are there. Definitely. Everything comes at a price. See, I feel happy in doing interventions. I feel happy when a patient with a blocked coronary artery, a stay elevation MI comes in the middle of the night and I do the procedure and he goes back home. But then that comes at a cost of you waking up at 2 a.m. in the night, going to the hospital, doing that case, coming back, and then having difficulty in falling back to sleep again, knowing that you have to go to hospital again tomorrow. So I was on call for last 2 days. So I did number of cases a night, but that depletes you of energy, that depletes you of your, that deprives you of sleep sometimes. So those are negativities. And second, it's a branch that involves emergency things. A patient comes with most of the conditions, they're emergency procedures, heart blocks, myocardial infarctions and all. And even the procedures themselves are very risky. It may be a stable patient, a stable angina patient that you're operating on, you're doing a procedure on, and suddenly something happens and he suddenly collapses. And then that requires a very tough person with a good mental focus to bring in all the strength and all the knowledge to treat that patient on the table. And if you don't act promptly, you may lose the patient in minutes, seconds. So this branch does involve that extra effort. I told you, doing cases at any time. It may be midnight, it may be day, it may be morning, any time. Second, the procedures are always emergency procedures. So that does, require a lot of grit and patience. That's the negative point.
So for our MBBS students, what would be your advice be? What kind of a person he or she needs to be to actually excel in this field?
You need to be patient and you need to be very, very vigilant. As a cardiologist, you need to pay attention to very minute details. A patient is lying on your table. You have to observe for subtle change in heart rate, subtle change in that ECG strip. And if you go wrong, if you by mistakenly inject even one bubble of air in that column, which is going into the coronary artery, the patient will collapse and die. If you just slightly push your wire, which is into the coronary artery of a patient, if you slightly push it against resistance and it perforates, the patient may die. So all these procedures are extremely risky procedures. So paying attention to details and being methodical and all, that is required. So if you're ready for that, if you're ready to be that, skillful and patient and, vigilant, If you're ready to do that, everybody is welcome. But if you're someone who doesn't like emergencies, I want to work in 10 to 4, and I don't want to be in emergency situations. I don't want to face relatives of patients who are dying, and then you need to explain them, hey, it's a difficult situation. A patient comes, say with a heart attack and cardiogenic shock, he has a 50% chance of survival, only 50% chance of survival. So how do you explain it to the family? Okay, I do the procedure, but he'll still have only 50% chance of survival. That's like a coin toss. So if you're a person who doesn't want to get involved in such conversations or such procedures, then you may like choose a different profession. I mean, a different branch. But on the other hand, I've mentioned the positives as well. It's so rewarding. It's so rewarding. It's so active. You will never be bored by the amazing cardiovascular diseases, the physiology, the pathology. It's amazing.
People normally tend to say about this, but the kind of work that you have been telling us about, the emergencies, the two-day call that you were, do you think this branch breaks you over time?
It may be overwhelming. It may, at least it may affect you physically and mentally. It can. But then, there are things that drive you. So if I'm happy doing a thing, if I get that gratification, if I get satisfaction in doing a procedure, even in the midnight, I don't think it will, affect me negatively. So I can fulfill my sleep in other hours. But if I save the life of a patient by doing a procedure at 2 a.m. and I see him and his family walk happily back home, so that's gratification, that's satisfaction, that's a positive result to my body, to my mind. That will keep me younger, rather. But yeah, if you're someone who gets, who is not happy with doing these procedures, if you're forced to do these procedures, you don't want to do some procedure, or you don't want to work for 24 hours, definitely it will break you physically and mentally. So it depends on what you choose and what you expect from life. If you feel happy doing it, continue doing it. If you feel it's breaking you down, choose a different path. I mean, it's a personal decision. See, if I tomorrow decide I don't want to do interventions, I just want to see patients and treat them medically, I'll do the medical part, or maybe do imaging. I can work as a non-interventional cardiologist. I mean, I can treat cardiovascular disorders, even a cardiovascular risk factor. Say, if you treat patients of hypertension well, if you treat patients with metabolic syndrome well, or other simple cardiology conditions, that's fine. You can work 10 to 4, work for those patients. That's great. On the other hand, if you get that kick from the procedures, from doing difficult things in difficult times, you're welcome to do it.
Did you feel toxicity in the Department of Cardiology?
Absolutely no. I was fortunate that both of the departments of pediatrics and cardiology, they're extremely, resident-friendly departments. I did my MD and DM in places the faculty were very cooperative, and and the duty hours, they were relatively less. So if I compare myself with a cardiothoracic surgeon, those who were doing MCH and CTVS, I mean, they would do probably double the amount of work that which I do. Even consultants, they will do double the amount of work. Their procedures last longer. They are non-stop doing a procedure for 7-8 hours. But compared to that, my branch, my departments were relatively easier. We used to get offs, pre-duty or post-duty off. So I was never like troubled by the number of duty hours. And I've seen people who work for 30 hours and they're happy. And I've seen people who work for 8 hours and they're unhappy. And I remember, I was in MD Pediatrics, and I had done the night duty, which means I had completed my 24 hours of shift. I had come, say, at 7 a.m. the previous day, and it was 10 a.m. the next day. But I was still full of energy. The reason being that I had to attend rounds from Professor Kabra. So the passion, seeing his passion in treating patients and him teaching students in rounds. So I would be even full of energy despite having worked for 30 hours, because I was getting a reward that I will attend his round, I will learn from him, and I'll learn from his skills in treating patients and how he speaks to their families. So this is a mixed bag of feelings and mixed bag of gratifications or disappointments. Somebody may be tired after 8 hours of duty, or somebody may be full of energy despite having 30 hours of work. So it's a mixed bag.
Do you feel that the return on investment on this field, cardiology, financially, psychologically, spiritually, does it actually measure out?
Yeah, the amount of hard work, your input is proportionate to your output. If you do more cases, you'll feel better. You'll earn more, at least in private setup where your salary is not fixed. If you do more procedures, you'll earn more. If you learn more difficult procedures, you are more skilled, and you're more skilled, you're more valued. So it's proportionate.
So, what does a daily schedule of a cardiology resident look like?
Well, at AIIMS, we are posted in different places. So one day you'll be posted, say, for a few months, you'll be posted in emergency. For a few months, you'll be posted in echo labs, echocardiography labs, or cardiac catheterization labs, or maybe seeing peripheral consults, or maybe other places around the wards and ICUs. So each day is different. But on an average, you used to work for about 10 to 12 hours a day, on an average. So that's a norm to work for 10 to 12 hours a day. Some postings are relatively easy. Relatively easy means labs like Holter labs or treadmill labs, where you are not, supposed to stay beyond 5 p.m. But some places like cath labs are very hectic, where you need to be around 24/7 for several months, for several days put together. I mean, some postings are hectic, some postings are light, and it's a mix. So you'll have a hard posting, and then you'll have a lighter posting. So you won't get tired, or you won't get exhausted at a stretch.
Like, cardiology is a high pressure job. The way you are telling us the stories, the way you were working. How did you basically psychologically handle that pressure?
You take it as a challenge. I mean, if I have a patient who is dying, that's an opportunity. That's an opportunity to serve such a sick patient and the family who's caring for that patient. So again, it depends on your mindset. You may be scared of that condition, or you may take that as an opportunity. So I belong to the later group. I'll take that as an opportunity. I'll take a difficult case as an opportunity for me to improve my skill, to do my best. I mean, recently I was doing a procedure. We do procedures under local anesthesia. We do talk to patients during the procedure. And he was saying that, Doctor Saab, mera procedure अच्छे से कर लेना. I told him that तुम्हारे से ज़्यादा मुझे, I would see you, obviously patient तो चाहेगा मेरा procedure अच्छा हो, but उससे ज़्यादा मैं चाहता हूँ कि procedure ये सबसे अच्छा हो. So if that's what drives me, at least.
Did you ever regret taking this branch?
No, not till this point.
Not even for a second.
No, no, no.
Any
I'm
time in your
happy.
career?
I didn't choose this path myself. God chose it for me, from one branch to other, from one dream to other dream. But finally, I landed in a perfect place. I couldn't imagine that I would do DM and then work as a faculty at All India Institute of Medical Sciences, New Delhi. So all this was planned by Almighty, and I'm happy. If I had to do it again, I'll do it again. If I have to repeat my residency, I'll do in the same department.
Of all the medical super specialties, which one do you think will have the highest potential in the upcoming 10 years?
Cardiology, yes, definitely number one, because the cardiovascular diseases are on a rising trend. You will never have enough cardiologists to treat the number of patients you will have in cardiology. See, if you talk of cardiovascular risk factors, hypertension, one third or one half of our population has it. If you talk of the leading causes of death, cardiovascular disease is the leading cause of death. So, and it's going to rise. So definitely cardiology. Then other branch, I think the branch, I don't feel that radiology should be the branch that should be scared from AI. It's the radiologists who will drive the AI projects. It will be the radiologist who takes up that job to create the AI model of that disease. So even that's and this interventional, the intervention tools are improving. So I believe second, radiology should be on a rise and not on a fall. One, because of the AI itself, and second, because of the upcoming technology, we are dealing with more diseases in a non-invasive manner. Many surgical conditions, which used to be surgical conditions, are now treated interventionally. So those branches. And third, I think neurosciences, neurology and neurosurgery put together. Again, the amount of workload, the amount of patient load, and the aging population and the neurological diseases, stroke or other degenerative disorders, they are on a rise. So these three branches, cardiology, radiology, and neurosciences.
Let's suppose if AI has to enter your field, where do you think it will attack first?
It's not an enemy. It doesn't have to attack. It's there to help. Say if we need an AI model for early diagnosis of heart attack, for example. So who will create that model? A cardiologist, a hospital, a big hospital with big data of patients with cardiac diseases, with so much of data on all the ECGs. We make these models. The doctors make these models, and then they help other doctors in diagnosing these conditions easily. So I don't see it as an enemy. I see it as an opportunity. So many cardiology students may take this AI as a future profession. So I see this as an opportunity rather than an enemy. At least for the next 10 years, that's what you mentioned. So for the next 10 years, it's an opportunity. Maybe beyond that, it may threaten a few areas, especially diagnostics. So if it's something a doctor diagnoses by imaging, by seeing an image, computer can do that better. Or if it's just diagnosing a clinical condition by looking at the list of symptoms, a computer can do it better. But if it's about interventions and surgical skills, I don't think AI is a near threat to that. Maybe in future, maybe 50 years down the line, when a robo operates everything, that's a different game. But at least for next, I think 50 years, interventional and surgical fields should be okay.
I hope that's true. Boss, do you think that after doing DM cardiology, a resident, a doctor basically, should immediately start a private practice or should work in a corporate or government hospital?
Well, it depends again on the person. So whether he wants to immediately settle down or he wants to further improve his skills. So because that will determine whether you want to work as a practice, you want to do your practice, because whatever you've learned, you then practice it. Or you want to upscale your skills. So you've learned something, you have learned some skills, and then you again join an academic center. Do more either fellowships or as a faculty in a government institute, in a research center, where you learn more skills. So I learn new skills every day, only because I've been in AIIMS despite the fact that I finished my DM in 2023. But I'm still at AIIMS. Why? Because I'm learning new things on a daily basis. If I quit this place, if I start doing private practice, probably my learning will be much slower and less. You get good exposure, clinical exposure, research exposure, even the interventional exposure in a good academic, large tertiary care center. That's much larger than what you will see in a small clinic. So it depends. If you want to pursue this habit of learning, improving, you should stay with government places. You should stay with large government, state or central institutes. If you want to settle, and that's also, it's a personal call. It's a fair decision. You want to settle now, settle with your family, start earning a fair amount of money, practice.
Do you think there is a need for doing any kind of fellowships after DM cardiology?
It's a difficult thing to answer. Technically, a person who has got trained in cardiology, DM in cardiology, so he is skilled enough to do most of the procedures. But then there are procedures that require even higher training. Some trainings which are not even available in India. Say if you think of transcatheter valvular interventions, which is very trending. So no place in India offers such training. So you need to go for some advanced fellowships outside this country. But that is for a brief period of time. You may go for a few months fellowship or maybe a 1 year of fellowship. And that depends on, do you want to pursue that branch in future? Do you want to deal with transcatheter valvular interventions? If yes, go for that fellowship. If no, if you're happy with the cardiology overall, DM in cardiology trains you in most of the cardiac procedures and most of the places and most of the patients. So this should be enough. DM in cardiology is enough. And especially if you work then in a government institute, in a good, large government institute, that should give you enough exposure, enough training. That should be enough.
What is the life of a DM cardiologist in a corporate hospital?
It's quite busy. The number of patients he sees, the number of procedures they do. So they will probably be working for the maximum number of hours. They come in the morning, they leave in the night. So that's it. And if you compare it to other departments, say somebody who is working in a non-clinical or maybe basic sciences, there'll be 10 to 4 job. But if you are in a super specialty, gastroenterology, cardiology, neurosurgery, cardiothoracic surgery, you will be overworked. No matter which hospital are you from, you will be overworked. State hospitals, central hospitals, you will be overworked. Clinical branch, they're always overworked.
Dr. Mohsin, I'll ask you the most important question of our podcast. What is the salary structure of a DM cardiologist immediately after completing super specialty, 10 years down the line, 20 years down the line?
So salary again depends on where you work. If you work in government, your salary will be fixed and it will be same as other departments. So a surgical faculty will earn the same as a faculty of blood bank, a faculty of anatomy, a faculty of other branch, or cardiology for that matter. But if you move outside government institutes, there your skills will be valued. So if you do tough procedures, if you do more procedures, if you do more difficult cases, so that will definitely earn you more money. And immediately after DM, it's quite common to see, salaries maybe 4 or 5 lakhs per month. That's an average thing. You may earn even more than that. And 10 years down the line, you may earn much double or thrice this figure, 10 or 15 lakhs per month. But that depends on your experience. 10 years of doing so many cases, more complex cases, and someone who has got advanced things, somebody who is doing, say, transcatheter valvular interventions, you learn much more than that. So the number, there's no end to the figure. But you may start at 4 to 5 lakhs a month, and then there's no end.
So do you think this branch can reach up to 1 crore per month?
I don't know of any person who earns that much. But yes, it has the potential. If you work in such an institute, say if you run your own hospital and you do these interventions, maybe many interventions on a daily basis, you will eventually earn 1 crore a month. It's not a big deal. But that depends. You run your hospital and you do so many number of procedures on a daily basis. You work that much hard, you can earn. And that's ethical money. You have a skill and you're doing it on a daily basis. You're doing so much of hard work, you can earn.
Do you ever feel that this branch in itself is, I won't call it an underpaid branch later on the life, but during the residency time or maybe immediately after residency, it's an overworked, underpaid branch?
You get relatively greater pay than other branches in cardiology. Immediately after your DM, you will get better salary than other branches. So it's not.
Let's suppose a DM cardiologist wants to set up its own private clinic. What is the basic capital required to run that clinic, and what are the equipments needed to run that clinic?
That again depends. If you just want to run an outpatient clinic, I think like a routine doctor, a clinic plus you may get an echocardiography machine. That should be okay, or a basic test like X-ray, ECG, or treadmill test. So that should not cost you more than 1 crore rupees, 1 crore rupees in total. But then if you start a bigger hospital, you want to do procedures, you want to get your own cath labs, that would involve several crore rupees. That's much costlier investment.
If somebody, a new DM cardiologist wants to earn the fame and name like Dr. Naresh Trehan sir, what would your recommendation be?
Well, that won't be the goal of most people actually. One, you get trained, then you need to have that entrepreneurship mindset, and third, you need to be at the right place at the right time. So that's it's highly improbable that you will achieve that amount of success, that you establish something like Medanta. I think he's the one from Medanta, right? He owns that chain of hospitals. So I don't even know how many they are, but it's very difficult. It's very difficult for a person who is just passed out and he has such big dreams, but it's not impossible. So as I mentioned, if you have the skill set, if you have the right mindset, the business entrepreneurship mindset, and if you start early, that's it. So probably he had the skill at a point when nobody else had the skill around him. So he was early to start. And then, so with that skill set, he must have had a good, obviously, entrepreneurship mindset. That's it. He succeeded.
So if I ask you, since you're from the same field, what traits make Dr. Naresh Trehan sir special? Because I have heard numerous anecdotes from people who have worked with him. Do you have anything that you can share with us?
I wouldn't answer this question. One, because I don't know him personally. The only thing I know is the Medanta. So I'm not sure the traits that he had to build that empire. So I'm not the person that I can answer. I can't answer this question. But yeah, one thing from my, perception is you need to be, persistent. on your mission. If your mission is to create Medanta, next Medanta, you need to have a mission. You need to build your principles. This is what I'm going to do in the next 5 years. This is the skill set I'm going to have. This is the ladder that I'm going to move up to reach that point. That's it. But I'm not sure about what his traits were. I don't know him personally.
His traits as a doctor were amazing. As I had a guest here who basically was a resident under him,
Okay.
and he was telling us stories that basically when Trehan sir entered the OT, everybody was silent, and he was a monster inside the OT. I mean, nothing could go wrong. But outside the OT, he was a jolly man. He was very normal. But inside the OT, he ran it like military.
Yeah, you need to be very disciplined. You need to be disciplined to do such cardiac procedures.
Yes.
That's what I mentioned in the earlier questions. Passion, patience, and discipline. So this would be the third thing.
So apart from private practice, what are the long-term options apart from this for a DM cardiologist? Career options.
Well, I think to my mind, they're very limited. You work in government, you train students, you train residents, fellows, or you work in private, you treat patients and you earn. I think that's it. An AI, you can do AI. You can make AI models in cardiology. I see that as an avenue rather than an enemy.
You know, the problem is, Dr. Mohsin, the earlier podcast was purely on AI. We did.
Okay.
All right. It was for Dr. Suryankar, and he's now an AI researcher. He's an Amazonian radiologist and now an AI researcher. And while talking, if you are into AI, he considers many things normal. But while we were talking, it was that things were purely technical for me. The problem is that we are asking a radiologist to be AI ready, but we are doing nothing to actually train them.
Yeah.
Not a third party course कि जाओ 6 महीने का कोर्स कर लो AI सीख लोगे. रेडियोलॉजी के रेजिडेंसी के दौरान आप AI का A भी यूज़ नहीं कर रहे, तो आप आने वाले 10 साल में रेडी कैसे हो जाओगे?
It should be there. Even I think it should be there right from MBBS. It should be a part of your curriculum, like how to do this, how to train these models. Even say if I read about AI papers, say I do read papers on AI, so those things are pretty new to me. The networking, computational things, and all neuronal networks, they are new to me. And I need to read them at this point of time. I have no knowledge of these things, say, from my years of training. So they should be a part of entire medical curriculum. They should be taught to medical students and during residency. And they should be given an opportunity to be trained in AI and to make models. I mean, we shouldn't rely on models made from the US, or they won't work actually. An AI model will work and it will deliver to the population subset where it was created from. So an AI model designed in one city may not even apply to a neighboring city.
True.
How can you extrapolate an AI model which is designed in US to work in India?
It has to be specific to the
It has
core
to
of
be
that
so.
city.
An AI model is derived from the data set, and the data set should come from this population. A data set that is created at AIIMS, for example, may not be true for patients who are seen in maybe in South India. So we need to create models and we need to be trained in that. So medical students need to be trained in doing AI, learning AI, or doing research in that and making models useful for hospitals, useful for common man.
And the second part is that they should be taught how to implement AI.
Yeah.
It's not about reading a newspaper, okay, that this AI has come, do this thing. We as doctors, first, we are very weak in maths, we are very weak in tech. All the tech that we know is what we see on Instagram and anything. You are talking to a person who's already a layman person that, okay, now you have to be ready for AI for the upcoming 10 years. How is that possible? If you are doing the MBBS curriculum, in every posting, AI should be taught how to be implemented. Okay, this is how it is going to make your life easier.
Yeah.
So it becomes a basic activity in the
there
next
is
10
scope.
years.
There is scope. Like AI has come up everywhere. So you can diagnose skin conditions using AI tools. You can diagnose ECGs using AI tools. So they should be made available, and they should be made, available to every student. Okay, this is how it works. So that they develop the interest, and then they start working. And probably a big challenge here we have is the data sets. So you need to have data sets to create the models. Where are those data sets? So in most of the big institutes I know, government places, there's no storage of data. So you need to have that first. You can't make a model without a data set. So you need data sets. And to create data sets, it needs more manpower and more dedication to do so.
I think the government needs to take very strict steps, stringent steps to implement AI patterns into our daily life. Why people are, if I think about it, why people are apprehensive? As doctors who have trained in the conventional ways of working for last 10 to 20 years now, suddenly you can't ask them to, change the complete thinking that they have. To tell them, okay, from tomorrow you need to use AI, how is that possible? In some ways, we are saying that the older generation will automatically go useless because the newer generation will only know AI. The government has to take protection of both the formats.
Yeah.
Everybody needs to feel secure.
Everybody should get exposed to AI and trained in AI.
Dr. Mohsin, let's talk about a preparation strategy as well. You have cracked all the exams. But my question again to you will be, can a student from a private medical college doing MD from private medical college crack DM in AIIMS?
Definitely. I've met people who have done their basic education from private college and then an MD or DM from AIIMS. One of my seniors was doing DM in neonatology. So she had basic medical education from a private college. She then did her MD from PGI and DM from AIIMS. So it's as I mentioned previously, these are MCQ exams. I mean, the obstacle to AIIMS and PGI is that MCQ paper. So if you know the question very well, if you prepare for those MCQs, you're through. Nobody's going to stop you based on your college. I mean, who cares whether you're from a private college or a peripheral college? You just need to answer those MCQs. And how do you answer maximum number of MCQs correct? Your preparation. Your preparation should be that top 0.1%. You need to be at AIIMS. To be at AIIMS or PGI, you need to top these exams. I mean, if your rank drops below 30, you won't get a good branch at AIIMS. And how do you reach to that rank 30? Your preparation should be like those top 30. If 2 lakh people appear, and only 30 are those lucky ones, so your preparation should match to those 30 people. So your preparation should be like top 0.1% performers of that exam. So if you have done that hard work, if your preparation is up to that level, it's just a matter of MCQ exam. Crack that exam and just walk in.
Between USMLE and AIIMS, what would you recommend?
If you say which one is difficult to enter, it's definitely AIIMS. Because if you compare the proportion of students who get to AIIMS versus the proportion of applicants, it would be less than 1%. Less than 1% of people who dream of coming to AIIMS, appear in an exam, work for years, write an exam, less than 1% will enter AIIMS. On the other hand, if you talk of USMLE, I don't know people who thought they will give USMLE and then they were not able to enter US. So you plan for USMLE, you appear in the steps, even some steps are now pass and fail, and with a pass percentage of, I would say, I think 60 or 70%. 60 or 70% of people who appear in an exam, they pass. So you pass, you match. It may not be a good center, it may be a less good center, but you will eventually match into a residency program in US. So that way, AIIMS is difficult, entering US is a bit easier. But if you think of the other side, if you go to US and get yourself trained from the US, from an institute in US, get your residency, then do your fellowships, then you're a much more valuable person. If you go to any part of the world, any place in the world, and say that I've done if I talk of cardio, I've done my cardiology fellowship from Mount Sinai Institute or something like that, or from Mayo Clinic. You are a much valuable doctor than I'll say I've done my DM and MD from AIIMS. I'll be less valued because I'm from India. My degree is recognized in India, not outside. But their degree is recognized in the US, other parts of the world, including India. So that's the benefit of doing it there. And AIIMS or other top colleges like PGI, it may be difficult to enter. So that's the brief comparison I could make.
Many students, every year come to me that, sir, this is my third attempt, this is my fourth attempt, but I'm still not getting the branch of my choice, and should I actually prepare again? What is your opinion? Should a student go for multiple attempts or should they settle for what they're getting?
Well, again, depends on the person. Because you can't convince a person who is mad after something, you can't convince him to settle for something less. So if you're such a type of a person that you can't settle for less, number of attempts does not matter. I've seen people, one of them in fact was my roommate in MBBS. He had cracked MBBS in his fourth attempt. But then in his MBBS, he was one of the top performers in the college, top performers of the MD. He did DM in gastroenterology. He was working in top institutes in the country. He was working in Tata. He worked in places even outside this country. He is an amazing gastroenterologist at this point of time. So the number of attempts did not matter for him. He had to land in a place. He had to just get that escape velocity, and once he achieved that escape velocity, he just escaped and he launched himself into the world. If you're that type of a person, I just need this thing, and I won't do anything else. You can give as many attempts. But if you're someone, who doesn't want to work harder, because you probably need to work harder if you have failed in a couple of attempts, then I think it's okay to settle for what you have. So if I was targeting radiology, but I'm not getting it in repeated attempts, and I'm getting, say, pediatrics, it's not bad. Because at the end of the day, a radiologist and a pediatrician, they can earn the same amount. And they can get a similar reputation. They can get a similar amount of joy and satisfaction. So no branch is actually bad. I mean, even branch like Opthal or ENT or Surg, any branch, even non-clinical branch, microbiology, can give you happiness. So if you're getting it, and if you feel that it's been enough, you're tired, you can take it and stay happy in that branch. And because let me tell you, I've seen people who are toppers join the branch of their choice and then felt unhappy about that branch. And on the other hand, I've seen people who have joined a branch which was not of their choice, but eventually they fell in love with it and they excelled in that field. They became global leaders of that branch. So it's, again, varies from person to person, depends on how much do you want a particular branch.
What were your sacrifices like when you were preparing for, you got on the first attempt? Would you have tried again? Especially in the case of DM. MD, though, you must.
Yeah, DM, see, I tell you, I got a rank 1 in this NEET-SS. I didn't even appear in counseling because I wanted to do DM only names. And if I was like ready to, okay, let it be. I'll repeat the exam, but I'll do it only at AIIMS. I eventually got rank 1 at AIIMS also, but it was a risk. And I was ready to take that risk. No, I need to do this particular branch in this particular institute. But that could backfire. Say if you fall sick on the day of your interviews. DM exam in AIIMS is like you pass an MCQ exam and then there's an interview. And so by chance, you may fall sick on the day of interview. So who cares? You will not get selected. Or you somehow underperform in that interview. Or you somehow underperform on that day of AIIMS. It all depends on your luck. How you play on that day. So it is risky. I took the risk. I may have failed. And I would be happy with the decision that I took. So you have to stand by your decision. If you decide that, no, I need to skip this institute, skip this branch, I need to reappear in the exam, it's your decision. You're happy with your decision. You will live with your decision. On the other hand, if it's like you're just comparing yourself to other people, or maybe some person is like forcing you, no, this branch is good for you, this institute, you should go to this institute, then you may not stay happy. And you may eventually end up breaking up. It may break your, emotionally, it may break you in terms of mental health or physical health. So that if you're that sort of a person, you should settle with the branch and ensure that you're getting.
Do you ever feel that, everyone around us is now calling overworking in the field of medicine, surgery, and renaming it as discipline?
No, it should be discouraged. Naming this as discipline should be discouraged. In fact, what is the need of hour is you get more doctors in these government hospitals which are so flooded with patients. Get more resident doctors, get more faculty doctors so that they are less, overworked. So that should be what should be promoted, rather than, making it a norm that you should work for 36 hours or calling that as discipline, calling that as mandatory. So that should be discouraged.
I mean, you are still at AIIMS. You have seen, college life, I would say. And I still believe there's a lot of toxicity in these fields. What is your opinion? How should that toxicity be countered?
Toxicity, unfortunately, there are few incidents, few places where these incidents occur. No place is immune to it. We have seen incidents of suicide and other harassment almost in all colleges. But, I think if you reduce the number of work hours and if you have, programs in place, system in place that cares of mental health of the working doctors, that is the need of hour. If a doctor is not feeling well in an Indian setup, he wouldn't even get time to discuss the problem with his colleague. Why? Because they both are overworked. I tell you one thing, in my DM, I had 3 batchmates, so we were total 4 people doing DM in cardiology at AIIMS. I don't think we got, ever we got a time that all 4 of us would get together and go somewhere in a restaurant or maybe. Not even one day. Because one of us will always be busy somewhere. Now, let's suppose somebody is having some problem. He wouldn't even have time to discuss with the closest batchmates. So there has to be a system that takes care of the problem. The workload, it is curtailed, and a system is in place that assesses the mental health of the working doctors, their personal problems. So a person may have a lot of problems in his life beyond work. It may not be that he's under a pressure of the workload, the number of hours, or the faculty, or the amount of work that he's supposed to do, or maybe thesis. There are many incidents of people getting harassed on thesis and all. But if there's a system who takes care of other problems from a student's life, he may have multiple other problems. If there's a system that addresses those problems, these incidents will certainly come down. And at present, I think we're lacking those systems. Nobody cares about a doctor's inner health, his inner problems. A hospital should have a system to scan, screen, and address problems, mental problems of doctors.
I think that's a very distant dream.
It is unfortunately a distant dream.
The way hospitals are understaffed, it's about filling up that job positions. The second is stopping that traumatic ragging experience between seniors and juniors. Because I'm still not able to understand what is this concept of bullying, ragging, assaulting verbally the newbie, the first JR1. What kind of system are we trying to create? Are we trying to create such kind of autocracy that, okay, अब तुम हमारे तानाशाही में आ गए हो, तुम नौकर, हम मालिक? What are we trying to create here?
Well, certainly this should be discouraged. Such a system, if it exists in a particular hospital, the senior faculty should actually stop that practice. Luckily, in places like AIIMS, you don't see such culture. Like, अगर कोई junior है, so he will be given utmost respect. And probably आपके podcast पे तो किस पे सुना था मैंने that a person was made to pay the entire bill जो भी seniors खाते हैं. But in our place it was the opposite. आज तक जब भी मैं किसी senior के साथ खाने पे गया मैंने कभी bill नहीं भरा है. And this is true for me also. अगर मेरे साथ कोई junior है खाने पे आए, never did I ask him.
Even or if today if I go with my senior मुझे पैसे नहीं देने देता.
It's a norm in our practice. It's a norm, but unfortunately certain places are there जहाँ पे उल्टा हो रहा है. So it's the responsibility of the senior faculty. If they know of this practice, they should immediately stop it. Because एक resident आया है जो JR1 है, अभी fresh system में आया, MBBS में तो कभी night duty की नहीं थी, अभी अचानक से उसको बोल रहे 1 हफ्ते में 3 night duty करनी है. So he's troubled by that. He's staying away from his family. And third, you're troubling him by bullying and all using this.
The problem was here is that the professors are driving this culture. वो कहते हैं कि तुमने सेकंड डे वाले ने खिलाया तो तुम फर्स्ट डे वाला क्यों नहीं खिलाएगा? तो सेकंड डे वाला कहता है कि मुझे भी अपना ROI निकालना, मैंने खिलाया था. और आपको सोचो ना, कुछ सेविंग ही नहीं बच रही. जितनी आपकी सैलरी आ रही है उतना आप खाने में जा रहा.
That's absolute. मतलब ये तो
सुन के लगता है कि क्या है ये.
It's surprising to know actually how can a senior doctor work like that with his juniors.
Guys, if you are going through something like that, as I've told you, make a post, tag me. But if you are not, be that second year who can change that culture, stop such practices, and just, be nice to your juniors. That's it. Boss, what will be your advice to a new MBBS first year student? I know, and they want to, they are dreaming to get into AIIMS. How should they plan their next 5 years?
I think they should first plan their MBBS first. I've seen this trend of people falling into like coaching modules. Now, they should rather focus on the standard textbooks. Standard texts, read those first, at least in your first, second years. Read those basic textbooks, Guyton and Hall, Robbins, and other books. Understand the basics. Then in your third year, fourth year, then you can actually jump into this coaching system. Then you can train yourself for MCQ exams. Your MBBS is not meant for your PG preparation. Your MBBS is meant for building the basics of 19 subjects. So my advice is to do MBBS on that fashion, on that manner, on that note. Learn the concepts. Build yourself as a strong clinician with a strong basic science base. Even today, I sometimes feel that, okay, this thing I cracked because I had read this thing in pathology. So that is not possible if you're training yourself for an MCQ exam. That is only possible if you utilize your MBBS in understanding a subject. And you only need to understand simple, basic science. You can't go into the depths where a PG student is supposed to. So there will be a postgraduate student of pathology also. There will be a postgraduate student of medicine also. So you don't need to go into those details, but the basic stuff, which it's a responsibility of the faculty to teach them, to make them understand, yes, this is the basic minimum things you need to learn, and you must read these things from a standard textbook. The next picture is doing MCQs for an exam. That's second.
Was for the last question for today's show. Simple two rules. You have to be super spontaneous and super truthful. So if you could change one thing about AIIMS, what would that be?
I would create a bigger AIIMS. By that, it's actually on that. It's actually doing that. It's opening centers like National Center of Aging or Surgical Block. I would create more such blocks, big centers, more faculty, more residents, more patients.
Do you think that policy of Safdarjung that they have to treat every patient should be implemented in AIIMS?
No. AIIMS it should have a particular principle. It is supposed to treat the sickest, it is supposed to treat the most complicated cases, and at the same time, it is supposed to generate new evidence. It is supposed to do top-notch world-class research. And that is possible. You can either be, the best, or you can best in terms of, quality or numbers. You can't be both. You can do maximum numbers, but then the quality will fall. Or you can do a bit less numbers, your quality will rise. So we should at least have one institute that deals with medical research, that generates evidence based on Indian patients, that generates evidence applicable to Indian patients. Because it may be different. A drug may be super beneficial in US population, may not be that beneficial in Indian population. Who will tell you that? A patient may be so difficult that he is treated only in an expert center like AIIMS.
Best way to relax after a long day.
Family. Spend time with the family.
Which AI app do you use the most?
ChatGPT.
ChatGPT?
Yeah, I do use it.
Pro le rakha hai?
Not pro. The things I need are done in basic version also. I mean, it's become actually, I feel it's better than plain Google. Even Google gives now AI summaries. But if you want to learn about a topic that you've never read about, you can actually interact with an AI model like ChatGPT and learn from it.
It's one of the best. If you start interacting with it, and if you take the pro version up, I mean, the normal version still gives you a superficial one. Pro version is crazy.
Okay.
It gives you such a deep, intense research on that thing. Na? Like, मैंने कुछ दिन पहले लिया है. I had to research on something. So my friend suggested, take it. I took it. Crazy research. मतलब I was basically एक बिजनेस को देख रहा था, तो उसने इस बिजनेस को पूरा बता दिया. शायद उसका मालिक को भी इतना नहीं पता होगा जितना इसको पता था. But it was crazy. So, what's your biggest goal in life right now?
Biggest goal, I'll say twofold. One is to settle, and second is I focus on improving on a daily basis. So my goal is to improve. I want to be a better myself the next day. I want to improve every single day. My goals are like that. I don't plan very long term. I plan that I want to improve this day. I want to improve the next day. So that's how. Let me enjoy the journey. I think the bigger goal, let it be planned by the Almighty.
What's the biggest risk that you've taken in your career?
Not many. I don't think of any big risk. Probably the one by leaving the counseling of NEET-SS. Even if I had a rank 1 but I didn't appear in the counseling, taking the risk I might get it at AIIMS.
I think that's... But thank you so much, Dr. Mohsin. It was a wonderful conversation, very insightful. I mean, it was just superb. Thank you so much.
Thanks for inviting, and it was nice interacting with you.
And thank you guys for watching today's podcast. I believe everything that you wanted for cardiology, the pros, the cons, the career, the preparation, you have everything in one episode today. So let's thank Dr. Mohsin for giving us such a great discussion. every point in detail and every point crisp to the core. And before you leave, do not forget to like, share, and subscribe. And who do you want as the next guest? Please do put in the comment section. Let's make India great. Let's stop harassment of our juniors. Let's make India a better country. Thank you so much and best of luck.